Postpartum depression. Transition to parenthood represents an important event which increases vulnerability to psychological disorders. It is a psychological and developmental complex process characterized by several personal and family changes which require adjustment. The birth of a baby can result in profound changes to lifestyle and recreation, sleep patterns, couple relationships, and identity. Both parents must cope with identity and family transformation. The parenting function development, which is different in men and women, usually results in the acquisition of a good parenting experience. Sometimes this process leads to psychological disturbances and psychopathological status like postpartum depression. Postpartum depression is a common disabling and treatable problem that affects the woman, infant, and the family. In clinical research, postpartum depression is variably defined as depression that occurs within the first 4 weeks after childbirth up to 12 months after childbirth. The estimated prevalence of postpartum depression ranges from 6.5 to 12.9%, or even higher in lower income and middle income countries. According to the DSM-5, postpartum depression is a mood episode that could have its onset either during pregnancy or postpartum. Between 3% and 6% of women experience the onset of major depressive episode during pregnancy or in the weeks or months following delivery, and 50% of postpartum major depressive episodes begin prior to delivery. Postpartum depression results in maternal suffering and diminished functioning, and is associated with increased risk of marital conflict and impaired infant caregiver attachment, as well as increased risk of impaired emotional, social, and cognitive development in the child, and suicide and infanticide. Postpartum depression is included in the DSM-5 under diagnostic criteria for major depressive episode, with a specifier of postpartum onset within 4 weeks after childbirth. Depression may start during pregnancy or beyond the first postpartum months. Postpartum depression is diagnosed when at least 5 of the following symptoms and at least one of the first 2 are present, with a duration for at least of 2 weeks. Depressive moods, sadness, feeling of despair, and inner void associated with a state of severe anxiety, loss of interest in daily activities, changes in appetite and weight, changes in sleep, changes in attitude and speech, extreme fatigue or lack of energy, feelings of futility or guilt, difficulties in maintaining concentration or decision-making, suicidal thoughts. This is a table that I was able to find in an article and is adapted from the DSM-5 and shows the symptoms and also the specifier with what we just explained. The diagnosis of postpartum depression is challenging because of changes in sleep patterns, changes in appetite, and excessive fatigue are a routine for women after delivery. Postpartum depression symptoms have been found to be associated with significant impairment in the mother's social and vocational functioning, and with impediments in the newborn's social, emotional, and intellectual development. Due to their marginalized status, women from immigrant and racial minorities are at higher risk. The rapid decline in the level of reproductive hormones after birth might contribute to the development of depression. Approximately 7% of new mothers have mild depressive symptoms called baby blues, which peak between 2 and 5 days after delivery. Postpartum blues is common and generally does not require intervention, and it's transient. However, its recognition is important because it is a risk factor for subsequent postpartum depression. Other risk factors are social demographics, such as younger birthing age, low level of education and income, unemployment, and being a single mother. Psychological and social factors also contribute to postpartum depression, like emotional distress during pregnancy and labor, having experienced a traumatic event within the last 12 months, stressful life events, and inadequate social support, increased childcare stress, low level of self-esteem, and limited parenting self-efficacy. Having a history of depression and anxiety before and during pregnancy is also a psychological risk factor. The relationship between partners is also important because it can function as a risk or a protective factor. While gathering background information, it is very important to pay attention to personal and family history of depression, postpartum psychosis, or bipolar disorder, especially if depression or bipolar disorder had been associated with pregnancy. Coexisting anxiety and obsessive compulsive symptoms are common among women with postpartum depression and should be investigated further. There are different methods that can be used to assess postpartum depression. The Edinburgh Postnatal Depression Scale, EPDS, is one of these. The EPDS is a 10-item self-report scale that can be completed in 5 minutes only and is sensitive to change in the severity of depression over time. Researchers found that introducing the test with 2 screening questions related to feelings of depression and hopelessness and lack of interest or pleasure in activities might help reducing false positive and false negative results. A positive response to either question can be followed by the EPDS questionnaire. And here there's a table where we can find the 2 screening questions. And if one of the 2 is positive, can proceed the EPDS. Two of the most relevant counseling approaches to postpartum depression are cognitive behavioral therapy and feminist approach. CBT is used as one of the most effective approaches to reduce symptoms of depression and anxiety, and is proven to be effective in reducing symptoms of postpartum depression. It does so by helping women to identify negative thoughts and beliefs that contribute to their depressive symptoms, and by giving them strategies to challenge and replace those thoughts with more positive and realistic ones. The contextual and culturally sensitive approach of feminist counseling is a logical choice for treating postpartum depression due to the psychosocial nature of many risk factors. It respects women's worldview and helps them understand themselves within the larger society context, acknowledging the influence of cultural expectations on most problems for counseling. It also empowers clients to become experts in their needs, strive for equality and balance in relationships, acknowledge cultural differences, manage societal pressures and traditional gender roles, and negotiate power imbalances, leading to increased self-concept and decreased symptoms. This approach considers the contextual forces of socioeconomic status, race, and age, and emphasizes connecting women with community resources to develop social support and connection, making it well suited to work with culturally diverse postpartum women. This is a presentation of a case study of a client that I work with. The young person is an 18-year-old female who is a stay-at-home mother of an 8 months boy. She lives with a partner who is the baby's father, and she also lived with a sister-in-law and her partner. She reported that when she was younger, prior to having the baby, she had symptoms of depression, and she also had urges to self-harm to cope with her stress and emotions. Presenting issues are low moods, symptoms of depression, passive suicide ideation, previous suicide, self-harm, new parenting role at a young age, and she's also struggling with self-care, lives with a partner, sister-in-law, and her partner, and everyone expects her to take care of the house. Therefore, she lives in a chaotic environment where no one cleans, spends all her energies looking after the baby and making sure the house is clean and tidy. Disclosed social anxiety and intrusive negative thoughts. Predisposing symptoms of depression when younger, prior to having the baby. Her parents separated when she was young. Mother works as a FIFO, so there's no like consistent support. She never accessed services before to manage her mental health. And during pregnancy, her high school wasn't supportive. Precipitating factors, adjusting to her new role as a mother, also arrangements, poor sleep, low mood, symptoms of depression. Perpetuating motherhood, poor sleep, house arrangement, lack of self-care routine, lack of self-awareness and emotional literacy, anxiety when baby cries in public, negative intrusive thoughts. Protective factors, young person is self-prepared, motivated, her baby, support system, partner and mother, sister-in-law and her partner help with the baby, and the partner might also engage in counseling. And also the partner and the young person are planning on moving out by the end of the year. So client's goals were to control her moods, improve her distress tolerance, feel better about herself, to working on self-esteem, and challenging negative thoughts. So the feminist approach was used to help the client understand and cope during the postpartum parenting distress and adaptation to parental role as a young mother in her social cultural context. The unrealistic demands and expectations from family and society and educational system were also explored and rationalized. Self-esteem and empowerment were topic of discussion, and the client was helped to set boundaries and become more assertive. Gender role expectations, emotional regulation and co-regulation, and roles as parent and partners were also discussed. Low moods and intrusive negative thoughts were addressed, and a developmental lifeline was worked on to gain some insight regarding the developmental transitions she was experiencing, and also to identify the strengths that she used in the past in challenging situations. CBT was used to introduce techniques like meditation, grounding, breathing. A self-care routine was implemented. Negative thoughts were challenged through Socratic questioning, and the young person also engaged in journaling to keep track of moods and thoughts. A feminist approach helped holding the space for the young mother and to make her feel understood and validated. Unconditional positive regards and active listening was also used. A very important factor was to value the unique life experiences and priorities of the client by respecting cultural differences and ideas. Also, counselor self-awareness about own values and social context. In feminist approach, counseling might help to challenge society historically traditional beliefs about how women cope with normal developmental transition, such as childbirth and motherhood. Thank you.